Susie Silver,
Here.
Marilyn Seeley, Barbara Service, Gary Simon,
Here.
Lisa Spencer,
Here.
Rick Tabor,
Here.
Leslie Tanoy,
Here.
Raylene Pennell,
Excuse.
okay.
Yes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. We have 11 members. Quorum. We have a quorum.
Thank you so much, Josephine. And we welcome everybody and a Happy New Year. Today we have a presentation by Richmond Luzar with Navion, Hawaii. And Richmond came to us last month. He was here at our December meeting and he asked, can I do a presentation for the group? And we said, well, why not? So he is a provider, rather Navion, Hawaii is a provider of hospice, palliative care, and their new primary care program. Okay, so Richmond, I see folks online. I think it's between.
Hey folks, how you guys doing? Also joining me is Dan Hare. He's the one with the title Hospice Hawaii DBA Navi in Hawaii. Is it alright if we share our screen? We have some presentation slides that
Okay. I think
we're
so,
wondering if
yeah.
we could.
Josephine, can you let them share screen, please?
They're supposed to be able to.
Okay, you should be able to.
It says sharing is not turned on right now.
Okay, hang on just a second. You know what? We've had some technical problems this morning. Yeah, so
It's a safety thing.
yeah, it's a safety thing because we've been changing passwords and things like that. So somebody went to go check on the other side where the host is to let you folks share. Okay?
All right, sounds good. Well, take your time.
Yeah.
They're trying to.
Okay, yeah, they're trying to adjust it
Well-
right now. So
While we're waiting for the technical difficulties to kind of get resolved, why don't I just introduce myself? So my name is Richmond Lazar. As Chair said, I'm a consultant in Hawaii working with Navian. And previously I had worked at City Council and the state and the federal government briefly. So I've been working with Navian since March, I think, of last year, and we're really trying to address a lot of the demographic changes. Um, I'm sure we all know on the Zoom and in the room that Hawaii is rapidly aging. So we're really trying to make an effort to address that with healthcare infrastructure. So I'll kick it to Dan before we get into the presentation to just give an intro from himself as well.
okay, he said the sharing should work now. Can you try it?
Everybody can see my
There we
screen now?
go. There we go.
Great.
Yeah.
Great.
Yeah, we see the screen. Hey, I'm Dan. I get the privilege of serving as president and CEO of Navian Hawaii. Many of you all know us as Hospice Hawaii. We've been around for 47 years doing this type of work for seriously ill and terminally ill kapuna around the island of Oahu. So looking forward to being able to share the next step of our journey with all of you guys today.
So with that, why don't we dive in? So really the way I see this presentation going, well, we have some presentation slides, as you guys can see. We'll run through that, and Dan will give sort of a background on a lot of the demographic changes and what they're doing in terms of establishing a new primary care slash physician practice program, and then we'll dive in briefly into some of the legislative stuff we're looking at, and then open it up to any questions. So with that, I'll kick it to Dan, and I'll click through the slides as we go.
All right, Rich, let's go ahead and move through it. Thanks, everybody. Sorry, I'm dealing with the head and chest congestion, so if I'm a little froggy, I apologize. All right, so where we're at, where we're going. Go ahead, Rich. So we all know the aging population here in Hawaii, what's happening, and currently on across the state, about 20% of our population is over the age of 60, and that's going to be rapidly expanding. And currently, about 8% of this population makes up Oahu's homeless population. 14 of those across the state are unsheltered. And what was interesting when my senior team and I, about a year ago, were looking at trying to bring primary care directly door to door to Kapuna on Hawaii, in Hawaii, we learned that there's about 70,000 Kapuna just on Oahu alone who do not have access to a primary care physician or don't seek primary care, and that number is about 100,000 statewide. So access to affordable primary care and wellness care, especially for aging Kapuna, is becoming more and more uncertain. And there's been a big drive at the federal level and at the state level now to be able to address that, and that's something that our nonprofit is working on. Next slide for me, Rich. So state projections indicate that between now and about 2050, the population share of people over the age of 65 is going to get closer to 30%. Right now, there's 200,000 on Oahu. It's going to be about 360,000 people between now and the next 10 years. And I have a nursing background. I've been a nurse for 25 years. I've been doing hospice and palliative care for 20 years. And the biggest issue with what we're seeing with this raising aging population is there's not going to be 28% increase in nurses, physicians, bed capacity at hospitals, long-term care beds, assisted living beds, et cetera. So we are working hard, not only as a nonprofit in the state, but also with the state ledge and with the governor, and even at the federal level, to figure out how can we take care directly to people, so that that is where we can increase capacity rather than trying to figure out ways to increase capacity in like a facility. Next slide for us, Rich. Here's just a slide that kind of shows over the next basically 25 years how that population continues to scale and getting closer to the 350 to 400,000 range over the next 25 years. So how does this impact us? Essentially, this aging population comes with multiple comorbidities. And I'd already mentioned that the majority of this population right now on Oahu doesn't have access to primary care. So they seek primary care in places that are not appropriate, like an emergency room. And so that just bogs down the system for those who do need access to these type of critical access systems. And so what we're trying to do is, like I'd said earlier, is bring this type of care directly to Kapuna. So there is a patient care and a caregiver aspect of bringing this care to people, but on the flip side, the cost associated with tens of thousands, hundreds of thousands of 65 and older people accessing care in an emergency room is unsustainable. It's been unsustainable for decades across the continent, and we are seeing it here in Hawaii. And I'll speak to it a little bit when we get to some of the future stuff here in Hawaii. But one of the biggest factors associated with us bringing this type of door-to-door care, primary care to aging Kapuna is it is going to massively decrease the cost of healthcare and healthcare utilization in the state. So essentially, I'd said earlier, we've been around since 1979. And one of the things when we did our rebrand from Hospice Hawaii to Navian Hawaii, when I took over as CEO a couple years ago, everybody was asking me, why did you guys change your name? And we changed our name because we do so much more in hospice care. We do hospice, but most people across the entire country only get hospice for about 2 weeks. And so there are so many other service lines that we provide. We provide palliative care, which is essentially serious illness care for people who do not have a life-limiting illness. And we do that for about 250 aging people right now in the state. We have a residential care center in Kailua, and we're building one on Gulick Avenue in Kalihi. And we do a lot of legislative and advocacy work, not just for us, but for other nonprofits who align with Keiki Tukapuna Care. We currently are the only hospice on Oahu who care for medically fragile and terminally ill kids. So we have about 45 to 50 kids right now on service who are either on our palliative care program or our hospice program. And so we continue to figure out ways to expand our scope to be able to just fill the gaps in our healthcare system. And that's where primary care has fit. All right, Rich, next slide for me. So what are we doing? Next slide for me, Rich. Bringing primary care to aging people in their homes is going to be one of the biggest things that we can do to drive results in the state of Hawaii. there are I'll bring up some examples here in a minute, but there are significant results happening on the continent with other large nonprofits like ours who are working with other agencies to be able to bring this type of care door to door, whether it's in someone's private home, in an adult foster home or a care home, in an assisted living, or even in long-term care, to be able to greatly increase access to wellness and healthcare and to be able to drive serious illness care where they're at, and then also helps improve certain outcomes, and then also saves a lot of money for payers, whether it's HMSA, UHA, MedQuest, or even CMS. So currently, we operate as a state under a fee-for-service model where when you do something for a patient, you get paid regardless of the outcome for that patient. And we are rapidly changing, especially in this space for serious illness and terminal illness care. We are moving toward more of a value-based model. So next slide for me, Reg. So essentially, what has been happening at the federal level and we've been bringing to the state level is what's called value-based care. And I'll land the plane, I promise. Let me just kind of explain what's happening with this. So the idea is that everybody who needs access to healthcare should have exceptional healthcare when they need it. What's happening right now is people get access to volume-based care, which is you go to see somebody, they see you, regardless of whether you're happy or regardless of whether you have a good outcome, that provider, that organization, that physician, that whoever is going to get paid regardless. That's leading to rising and escalating healthcare costs, and it's also leading to just mediocre, if not poor outcomes. And so what's happening is the federal government has been pushing these models through the Center of Medicare and Medicaid Services to help drive what's called accountable care organizations. And these are essentially middlemen organizations who make sure that providers like Navient Hawaii, who take care of people that we're privileged to take care of, actually do a great job of taking care of them, that their symptoms are well managed, that they have access to appropriate health care, and that we save money to the system. And so, what is happening at the federal level is CMS is making it very clear that over the next 4 years, every physician who is a primary care physician has to be aligned with an accountable care organization. No more just billing a payer because you saw a patient. You're going to be able to bill a payer, but you're only going to get paid if you actually did something good for that patient. So ultimately, what we're wanting to do here in Hawaii is there are excellent large practices like Queens and HPH Medical Group. There are excellent independent practices. All of them have brick and mortar facilities where people come to them. The majority of us on this call see physicians where we go and see them. That's not what we're trying to do. What we're trying to accomplish are those kapuna who are not able to go into town, who are not able to go to see a physician. We're going to bring nurse practitioners and doctors directly to them. And then we are going to align with one of these accountable care organizations and then ultimately create our own so that we can be able to drive this very effective system that creates exceptional care for people who need it, make sure that they access healthcare appropriately, and then saves gobs and gobs of money to the state. And then as a nonprofit, the great thing of this is we're just going to take all those savings that we're able to generate and just put it right back into our programs, expand our reach, and then be able to just keep this kind of flywheel going of caring for more and more kapuna as they need it. Okay, Rich, next slide for me. This is just a breakdown of the difference between fee for service and value-based care. But essentially, I broke it down earlier where it is. Fee for service means it doesn't matter the outcome for a patient. That provider gets paid regardless. We are moving in America to a model where a provider has to provide you a great experience with a great outcome, and then based on that, they're going to get paid based on that experience for the patient. That's the difference between fee for service and value-based care. So what are we doing? We have already established a separate organization. It's called Navient Hawaii Community Providers. And what we're going to be doing is standing up a geriatric primary care practice. We're going to start in April. And we are going to be bringing what I just spoke about. We're going to be bringing primary care. So this is high needs primary care. So this isn't designed for me, and it's mostly not designed for anybody on this call. This is designed for people in their late 60s, 70s, 80s, multiple diagnoses, lots of symptom management, advanced care planning needs, caregiver breakdown situations, people who have been in the hospital multiple times over the last year or so. This is the cohort of patients we're looking for. There are tens of thousands of them on this island and across the state. And so we're going to be designing this model to go directly to them. We start in April. And what it's built around is value-based care. So it is designed to provide exceptional outcomes for patients and then also save money to our state and to our other payers. We will always be billing fee for service. That model is baked in inherently to what this is. That allows us to be able to actually drive the labor and the costs associated with running the organization. But the value-based component is if we deliver on the benchmarks with patient outcomes, if we deliver on the benchmarks of actually saving the healthcare system money, then we share in those savings with either CMS or HMSA or United Health or even MedQuest, and then we get a portion of those savings, and those bonus dollars allow us to be able to expand our impact and our reach. What my goal is that by the end of this year, we have about 600 to 700 Kapuna under our primary care umbrella. Over the next 3 years, we want to be able to get to about 5,000 total unique lives associated with our primary care practice. And then from that point, we'll decide, do we continue to scale this? And then how that looks to be able to fit and meet the needs of all the aging Kapuna across the whole state. So I just mentioned essentially this year we're looking at roughly 350 to about 600 total Kapuna served. It depends on a couple of different factors. We are going to be launching our program at One Kalakaua. Many of you might be familiar with this assisted living facility, but we're going to be driving an early cohort there. And the idea of doing a pilot isn't because we're trying to pilot some care program. There's a lot of complexities in the back office side of doing this work around billing and our electronic medical record and e-prescribing and a lot of these systems that we need to make sure are fully ready to roll before we take it island and statewide. And then ultimately, between about 27, 28, 29, and 30, we want to start aligning what we're doing with an accountable care organization and other partners here in the state who are wanting to do a lot of the same work.
Great. So I'll take over now. Thanks, Dan.
Yep.
Excuse me. A few things that I would just highlight. I think one of the big things to take away from Dan's presentation is really this distinction between fee for service and value-based care. As Dan mentioned, and I'm sure a lot of you are familiar with this, but and excuse me if I'm being redundant, but there is really this shift nationwide from having a health issue, going into the doctor and paying to fix it, and bringing people under the care of an organization that is tasked with the responsibility of providing the right care at the right time to the right people, right? Making sure that really the distinction is preventative versus reactive, right? Fee for service is more reactive. When you have a problem, you go into the doctor. Value-based care is more preventative, and organizations are tasked with the health of their patients, essentially. So I think that's really something to keep in mind. The other thing that I would say for Navient's primary care program, and Dan alluded to this, but they're really trying to send people to Kupuna where they're living, right? As he mentioned, a lot of people are not able to drive to their primary care doctor, or they don't even have a primary care doctor. But under this model, you're sending physicians or nurses or whoever to Kupuna where they're living so that we're able to proactively address their healthcare issues and make it easier or lower those barriers for them to get good care. So transitioning really quickly into just our third phase, and we're almost over. We have about 5 minutes left. I just really wanted to run through a handful of the initiatives that we're working on from beyond this primary care model. So I know with the Kupuna Caucus, there is a measure that's related to permitting. We have kind of a similar measure. I think the Kupuna Caucus one is related to improvements, but we have a bill that's coming through that would address special needs housing. So last year there was a bill, SB 66, that was passed for single family, multifamily, just residential housing, to create a permitting fast track because there are so many barriers at the city and county level. So this would do a similar thing, but it would expand it to also things like hospice residential facilities, or things that are addressing people with special needs housing, to be able to create the be able to build them easier without falling into some of these permitting hiccups. I would say for this, with kind of a fast track, we're not saying that it's not going to be safe. It's not going to go through Department of Health or any of these other approving agencies. It's really for the county permitting specifically, where we're making sure that those permits are getting fast tracked rather than, and when I say fast tracked, still checked by DPP, but just uh, done in a more efficient way. Also at the county level, there are some regulations right now about group living facilities, which hospice facilities and other similar special needs facilities and things like that fall under. So there's kind of a distinction between small group living facilities and large group living facilities, and then there are associated regulations with those. We're trying to bring, particularly for those ones that are already state regulated, for them to all fall under one net so that you don't have to hit additional barriers, especially for these special needs type housings when they're being put up. Another issue, and this is more in alignment with our primary care model. Uh, uh, at HHFDC, they award LIHTC projects every year. These are where federal government is giving money to basically put up a lot of affordable housing. We want to make it so that some of the criteria that are set for how projects are awarded, um, rewards projects when they are doing special needs housing or kupuna housing, to pair that housing with a service provider. So I think there are a few models on the mainland of housing projects, kupuna projects that went up that partnered with some sort of healthcare provider to be able to service all of the kupuna in that building. So this is an example of trying to just make things a little bit more efficient when we are putting up kupuna housing, and be able to create a better marriage between healthcare and housing. Uh, the One more thing, there's the Kailua home that Dan mentioned. That's a hospice facility. We're trying to bring this into Medicare certification, and then we've also talked about uh, bringing healthcare and some of these models that we've talked about to our kahale. So that's really it. Here's our contact information. I mean, if you guys have any more questions beyond the Q&A that we're going to do right after this presentation, feel free to reach out. My cell's in there as well. So, I think we're always interested in talking story about a lot of these issues, because I mean, we spend a lot of time thinking about them and talking about them. So, with that, we'll open it up to any questions, and thank you guys. Thank you guys so much for having us.
Thank you so much for your presentation. Questions from anyone?
So this is Stephen Lang. I think Navian's move to try and provide geriatric primary care is great. I think that's something that we welcome and would be supportive of. I have some questions about the ACO arrangement. You mentioned that it's ACOs are limited to traditional Medicare, beneficiaries. So does that mean that beneficiaries who are covered by Medicare Advantage plans would not have access to this arrangement or these services?
It does not. What we're going to be doing, this care model applies to everybody who needs it in the state. The easiest path forward for us to make this financially viable long term as a nonprofit is to align with an ACO under traditional Medicare. We are aggressively working right now with MA plans, with HMSA, with UHA, and other payers to figure out other value-based agreements so that we can get paid for those patients outside of fee-for-service with everybody who's not traditional Medicare. And so my board has already given us the blessing to be able to take care of all those patients at a fee-for-service cost, which runs at a loss because it's the right thing to do. But long term, my hope is that all of our payers associated with everybody who has access to healthcare in Hawaii would have access to this, and we would be able to financially get paid for it, but we are going to do it regardless.
For the existing traditional Medicare beneficiaries. How is it determined which ACO they get linked to? I mean, does the patient have any choice in the matter, or does it just happen based on who they're getting services from?
Great question. There's two ways they get it. It is patient based. They can voluntarily elect for a primary care practice who's aligned with an accountable care organization that they would be their primary care doctor. The other way it happens is through the provider who bills the most for a specific diagnoses and specific types of visits actually has that patient what's called attributed to their organization. And so if somebody's just bouncing around, they don't have any consistent primary care provider, the person during the fiscal year who actually had the most billable claims for that person would actually have that life attributed to their accountable care organization. But the point is to have a consistent relationship with the patient. You follow them through a whole fiscal year, you manage their care, and then the savings comes from managing that one direct patient, but it's all patient choice driven.
Another question is, what is can you tell us anything more about the reimbursement model? Is it primarily fee for service supplemented by, incentives of various kinds for outcomes based on quality or the patient satisfaction, that sort of thing? Or is it something different from that? Just curious.
Yeah, good. Excellent questions. First of all, there's only one outcome, and that's financial driven at the moment. All of the models coming out of CMS are all financially driven. The way that it works is, and these models have been in existence now for about 4 or 5 years. And just this last 12 months, CMS has released 6 new models around chronic care management, primary care physician management, and then also what is called a head, which is what Hawaii is in. And we are in the second cohorts of states that are going to be onlining what's called the AHEAD model, which again is a value-based accountable care type of thing. But to answer your question, the way that it works is you come into a contractual agreement with one of these accountable care organizations and you say, okay, for our 2,000 patients, we're going to save you 8% on the average cost of a beneficiary for a whole year times all of our beneficiaries. This is where it gets a little complicated, Steve, but all of us, myself, you, everybody in the room, we all have what's called an HCC score. It's based on our past medical history. It's all the diagnoses that we live with. It's our med lists. It's all of these things. There's an average score associated with that, and there's a cost associated with an HCC score. So what happens is you run all these numbers, and then you come into an agreement with CMS, and you say, we're going to save you all 6% over the next fiscal year. And if we hit that mark, then you agree with the accountable care organization that we're going to share in the savings. And it's all contractual from there. So here's an example. Last year, 2024 results, which were published in 2025, there were 100,000 people on the continent who are under these types of agreements in high needs ACOs, 100,000. The average savings across all the ACOs was 5,000 per patient. Doesn't sound like a lot, but when you multiply that by 100,000 patients, it's a $500 million savings to CMS. And depending on contractual agreement, CMS may have paid out half of that to these organizations who delivered that care. But the government saved 250 million, and then the organizations who delivered the care got an additional 250 million in bonuses to be able to deliver the care. So that's how it's funded now. And the new models that are coming out are pretty much funded the same way. They're just they're the trick though is that there are downside risks the longer the agreements. And so when you enter into these agreements, your first 3 years of a 5-year agreement are risk free. So if I don't save money, I still can bill for fee for service. I just don't get the bonus. But once you hit years 4 and 5, if I said I was going to save 6% and I only save 4%, the gap on all of my patients, I actually have to write a check back to the government. So the concept isn't perfect, but the concept is accountability to the providers. We have a responsibility to our patients and to the state and to our payers that we should be doing whatever we can to make sure that patients have excellent care, appropriate care, and to be able to do this at trying to save some money. And so it's not perfect, but that's pretty much the system as it stands.
Thanks. That's helpful.
Very informative. Marilyn has a comment there. First of all, wow, this is really something I have been, I think she missed the rest of this paragraph, but the second one is associate. I think been associated probably. Okay, the second one is to Dan with Navion, and before, since Ken Ziri was CEO. Are you
Yes.
working with Senator Morikawa and her development for service package for housing? That's number one. Number two is, how will you deal with the shortage of healthcare providers?
Okay, I'll answer the second one first, and then I'll let Rich talk about all of our legislators and folks that we've been working with on some things. So, um, it's hard to answer this question because Navi in Hawaii, in my 18 months here, we have not had a shortage of being able to hire and retrain the best people. I think a lot of folks are drawn to our mission and our vision and what we're trying to accomplish. In 18 months, we've hired 100 people. The majority of those folks have been nurses or mid-level nurse practitioners. And in our primary care program right now, we have 3 full-time doctors and about 7 mid-level nurse practitioners. So right now, at where we're at, I don't have a capacity issue, but there are significant issues with capacity constraints into the future. I don't know who's in the room. I don't know who's representing health systems or nursing associations or any of those types of things, but there is a particular draw to this type of care, mainly because I'm a nurse myself. I mentioned that earlier, but there's a draw to the quality of life associated with this type of community-based, door-to-door type of care. What we are talking about doing is not volume-based, but it's outcome and people-based, which is very different than a provider who works in a clinic who is paid on volume and seeing patients every 15 minutes. And so I'm optimistic that what we're trying to do here will attract more people as we grow and scale to be able to do this work, because it'll get them out of some of those volume based or financially driven type of care models. But for right now, we haven't seen at our organization a shortage in healthcare providers. Rich, do you want to speak on Senator Morikawa or even our work with Senator Moriwaki and what we're doing?
Yeah, Senator Moriwaki, we've met with. And we're actually Dan's giving a presentation to the Kupuna Caucus, Senator Moriwaki's Kupuna Caucus in an hour and a half. But we've met with, I want to say roughly out of the 76 legislators, around 25 of them, about a third, and are continuing to do that. I realize now that you asked that question that I forgot to talk about one of the other bigger initiatives from a legislative standpoint that we're working on. So we've talked to both of the health chairs, Senator Sam Winshura and Rep. Takayama, about creating a hospice working group. That I think is it's a big initiative for us because there are just so many, from a regulatory standpoint, there are so many issues associated with hospice. I know, on the mainland there have been states where uh, uh, the state has been flooded with bad actors, or really just hospice providers that are just trying to extract as much money from the population as possible. So that's an issue that we're trying to address and make sure that Hawaii hasn't had any of those issues really to this date, but we want to make sure that nothing like that happens in the next 10, 50, or really ever. So that's one of the components of it. There are also some regulatory components about the long-term care benefit for Medicaid, and in particular room and board, issues like that we would like to work out. And really, if you guys have any other recommendations for the hospice working group to consider, we're in the process of writing the reso right now. So would love to include any of those issues that you folks may be aware of.
Thank you. Any other questions? Okay. If not, well, I don't see anybody with their hands up there too. So with that, we'd like to thank both Richmond and Dan for presenting to us this afternoon. It is, just to end with Marilyn's comment here. I love the concept. Primary prevention is top of the list. And if anything, that's what we should be looking at as preventive health care. So thank you very much, gentlemen. Have a happy new year. And good luck at today's presentation.
Thank you all. Have a great day.
Thank you guys.
too.
Aloha.
Thank you. Okay, and that we will come back to our PABEA meeting. The minutes of December 5th were distributed to you by email. We need a motion to the minutes.
Are you supposed to do that?
That's right. Sarah has moved.
Move to accept the minutes as written.
Okay. We need a second.
I'll second.
Okay, Rick seconded this. Okay, it's been moved by Sarah, seconded by Rick to approve the minutes of December 5th. Okay, you all have a chance to read it? Okay, are there any additions or corrections to the minutes? Okay, if not, the minutes will stand with no corrections or objections. Thank you. Going on, report, the EOA Director's report.
First of all, Happy New Year, everyone. We're 9 days in and it seems like it's been a long year. Anyway, but Happy New Year, everybody. My report is pretty short. I highlighted different things happening at the federal landscape as far as, and this is all around prevention too, is some of the awards that have been given out around falls prevention, chronic disease self-management, education, and innovations in nutrition programs and services. So just highlighting that. I do have my annual report that went to the state legislature. Did we
Yes,
send
you
it?
sent
Oh, we
it to
sent
us.
it out.
Yes,
Okay,
you
great.
did.
So
It's
PABEA
already
does
sent
have
it
that.
out.
Okay. I just want to highlight, we did a lot of good work. I want to thank not just my staff who are constantly working very hard, but also our area agencies on aging, because everything in this report is what the Aging Network is working on. So very grateful. Our ADRC handled over 38,000 calls, helped over 2,400 participants in long-term services and supports. The Kapuna Care Program provided community-based services to over 5,200 individuals, 58,000 hours of respite care statewide. Long-term care ombudsman program conducted over 1,000 facility visits and investigated 241 complaints. Hawaii SHIP assisted over 13,000 residents with Medicare counseling, outreach, and application support, which was a 17% increase from 2024. Senior Medicare Patrol educated over 12,000 residents on fraud, errors, abuse, and non-health related scams. Our Healthy Aging Partnership offered over 3,000 hours of evidence-based education and expanded our enhanced fitness to 508 participants statewide. Veterans Directed Choice, our Veterans Directed Care program here in EOA, increased our numbers of veterans served by 43%. And then our Hawaii Dementia Initiative, you guys have seen, I think, if you turn your TV on during that whole public awareness campaign, you know what we've been doing around our Hawaii Dementia Initiative. But again, a lot of great things going on, still a lot of moving parts. As I've told my staff, just continue the good work. I've told that to the county execs too. You know, there's so many things happening, I think, at the national landscape, but just to keep honing in on how we can support our kapuna, our caregivers, and individuals with disabilities out in the community. And that's my report.
Thank you very much. And, Director did send out to us her report to the legislature before the session, and that's required every year. And it kind of draws on to the agency's plan, to the state plan, which we do need to consider as we move forward.
Oh, can I add one
Oh,
more
yeah.
thing? So sorry. And attached to that by statute, every 2 years, we need to update the Alzheimer's disease and related dementia strategic plan. So the first 12 pages is the annual report, and then the updated ADRD strategic plan is attached to the report. So yeah,
Okay.
thank you.
But thank you very much for sending that out. Great Chair's report. Happy New Year, everybody. I hope you all had a very good and safe Christmas and New Year's, and hopefully Oahu was not as noisy as in previous years.
Oh, it's
Okay.
quiet, actually.
Okay, but going forward, it has been a very quick, short month somehow. Director and I have been in contact either by phone or by Zoom, just to keep us updated as to what's going on, how to streamline our meetings to make sure that we cover things that are important to everybody. And the speakers that we do have, they are speakers who either approached us because they have information or programs, shall I say, that would benefit all seniors within our community. And it's not only the vulnerable, but you know what? The person who we all think is very sustainable they all of a sudden find themselves to be a vulnerable person, as we've all seen with the scams and things that we have online. And I do have to reiterate the part about the scams. It is something that is out there, it's real. People, especially Oriental people, they shame. They don't want to tell somebody that their family is taking money from them. They think they're helping. So if anything, it's something that we need to share this information out with others. Okay, going on that, we will go to Legislative Committee. Tabor.
We met this morning, Legislative Committee, and we, so Kapuna Caucus today, there's a change. You may have seen it in the email. So we're waiting to actually approve the Kapuna Caucus until we finish those 5 bills, until we actually hear from that. We had 2 speakers this morning, great speakers. So Rep. Lisa Martin came and spoke on homelessness. So she's the Health and Homeless Chair. She presented 4 bills, three or 4 bills that she's sponsoring, that we'll consider. And then that was followed by Kobe Chalk from Alzheimer's Association. And he talked about their 3 bills that they're looking at as well. What else? That's it. So next time, hopefully we'll know more about what the bills are, and we'll go forward with what we're going to support. Oh, we did pass food, shelter, safety as kind of our overview for the bills that we're looking at. That was one of the things that we passed today as well.
Thank you.
That's it.
Okay, Plans and Projects Review Committee, Lisa?
Thank you. Due to scheduling conflict, I wasn't able to participate today, so we did go ahead and cancel the meeting, and we will meet again next month at 9:30. So thank you.
Thank you so much. Recognition and Awards Committee, Rick?
Okay, so we met at 9:30. We're gonna move it back to 9 o'clock for our next meeting. We voted on June 12th being our Older Americans Month for the state celebration. I've asked, I know she's on here, Susie and her team. We're looking at maybe doing a brunch and starting a little bit earlier. So we need to hear from 15 Bagside Arcadia system as to whether that works. So starting a little bit earlier and serving a meal earlier and then having the program after that. That's about it. It was a good meeting. So Gary, Barbara and we were going to ask for more help, but Gary and Barbara assured me that we got the coverage we need, so we'll be good. But if you did want to help with recognitions and awards, the door's open. Okay.
Thank you very much. Moving on, unfinished business, and this is something that Director brought up to us when we were having all those incidences, but maybe it's something that we may not need to proceed with. What do you think?
Yeah, so this was under unfinished business, and it was that whole discussion about, do we need to look at the Hawaii revised statutes, which says that, we have to have so many meetings a month, and then we wanted to make sure that our agenda aligned with, so there was that whole discussion, right? Does our agenda and what we're presenting after committee meetings align with PABEA? And we thought, do we have to have maybe less meetings and more committee meetings? So there was a whole discussion around that. And I think after further review, I think we checked with the Office of Information Practices and all of that, that we decided that we'll keep the Hawaii revised statutes the way they're written in law. So unfortunately, this was already still on the agenda. So I guess, I'll ask you if somebody could possibly make a motion to take that off.
Okay, so hearing Director's comments there, can we have a motion to due to the report that the Director gave us, that this is not necessary? Can we have a motion to that? Sure. So move.
Can we state the motion?
Okay, the motion is, okay, you better write this down, Masha. The motion is, okay. Due to additional information, this proposed change is no longer necessary. Or you want me to read the whole thing about changes to the Hawaii Revised Statutes 3349-4 regarding the composition and number of meetings per year of PABEA has been addressed by the chair, by the director's report. Okay? Yeah, we need a second.
I'll second. Oh, Steve.
Steve will second that, okay? Any discussion?
Who was, sorry, Sarah, who was requesting
Okay,
the,
the request came that when we had this unfortunate thing that happened a few months ago, that was one of it. The other part was that we felt maybe we weren't having enough time to really do a real good committee meetings, you know, that maybe that hour or hour and a half was not sufficient enough. And the suggestion was, well, what if we met every other month and the committees could use that other time? But after finding, you know, further review of this, and the statutes, it's no longer necessary for us to do. Okay. That was the reason for it. Okay. Any other discussion? Okay, all those in favor of the motion to remove this from the agenda, say aye.
Aye.
Okay, opposed, nay? Okay, you have adopted to remove this from the agenda, so it will not go forward anymore, because action has been taken. Okay, new business. Not sure if you folks have checked your calendars. Okay, but April 3rd just so happens to be a holiday. Okay, which means that is the first Friday of the month. So being it's the first, I saw, Stephen, I thought of you. I really, Stephen, I thought of you. Okay, when I saw that, I was like, oh my goodness, I apologize. I really do. But, you know, I have no control over a state calendar or a federal calendar. But
Easter takes place.
yeah, and so the proposal is to change our meeting date from April 3rd, 2026 to April 10th, 2026. And this doesn't really need to be voted upon because the bylaws clearly state that if the first Friday falls on a holiday, you meet the following Friday. Okay, so this is just for information there for you. Okay. And other than the June 12th, there should be no other changes. Okay, as far as I know, June 12th is the luncheon. The June 6th is okay.
and
So we're gonna have to meet. No, why? It's July 4th is not a, July 4th is not a Friday.
July 3rd is, which is the Friday, which is the holiday.
Oh. That is up to the next chair, because there is an election in June, so, okay, I mean, just, thank you very much.
First Fridays, I tell you.
But, the calendar is usually made from July till
But it'll follow
June.
the same statute anyway, that it would be the next
It will,
Friday.
yeah.
Yeah, you automatically move it to the
That's
next
true,
Friday,
yeah.
but thank you. I'm sorry, Mr. Lung, there's another one now. I don't know, are there any others that first Friday falls on a holiday? Okay, sorry about that, okay. And this you don't need to vote upon because, the RAC chairs did tell us that Older Americans Month celebration will be at 15 Craigside on June 12th, 2028, okay? The next one, oh, number 2, I missed that one. And this is chair, our director has much to say about it. Discussion of current membership and new members for 2026, 2027. If you folks have been keeping up with your terms, some people.
I have it here.
Some people's terms will be going out pretty soon. Some have already will expire 2026.
Right.
And you need to reapply, or some were even 2025. If I'm
And
not
we're
mistaken,
carryovers, yeah.
and who are carryovers and such as like that. Okay, so I will forward it
Yeah.
on to director.
Okay, so first is, and I'm not sure if she's on, but Poki'i's term. She's a carryover, so if she wants to continue, and we'll send her an email if she's not on. She will need to reapply this legislative session to be carried on.
She is on.
Oh, hi, Poki'i. I didn't realize she was on. Okay, and if I don't, I was gonna go through the whole list, but if I don't bring you up, that means you guys are good, okay? Bill, thank you so much for your service. Your term's coming to an end, right? So he's had his 8 years with us, June
No.
30th, 20. But we're always looking for Maui membership, right? I know I spoke with Rowena. Bill, if you have anyone that you maybe have in mind, we can have a conversation about that. So, we're gonna need someone to be our representative for Maui County. So put that out there. Sarah, you're good. Stephen. Yours did expire, your first term,
Right.
2025. You are also carrying to, like Bookie, you just reapply for this legislation.
Right.
Shelley, thank you so much. You have, I can't believe it's been 8 years. Anyway, yeah, so. So we talked about it earlier too, trying to find someone to represent the Gila side as we move forward. Yeah, thank you. Susie's good, Marilyn is good, Barbara's good, Gary's good. Lisa Spencer, thank you so much. She's in her first term and we look forward to her continuing with us, but she also will have to reapply for term 2. So Lisa, if you have any questions on that, I'd be happy to assist you. Just got to go to boards and commissions and like you did the last time. And Rick, you also have to reapply for term 2 because, okay, good, he's ahead of it because he's on a carryover just like Stephen. Yeah, okay.
Yeah, so if we reapply, we just sit tight and wait. Okay.
Yeah, we're gonna have to wait and see when they start to do those hearings. We do keep an eye on that during the legislative session, and you guys will probably get word via email too. Okay. Leslie, you're a carryover also. We have a lot of carryovers this year, so we'd love to have you stay on and ask you to reapply. Thanks. And Raylene too, so we can discuss that with her. And I think that was it as far as our PABEA members. And I know we have our new ex officio with the Department of Education on.
Correct.
Yeah, so that's exciting. Ryan. Right?
Yes, Ryan's our.
Yeah.
From DOE. Okay.
We'll call you up later, Ryan, when we get to the ex officios, but welcome aboard. I'll reach out to you and we can have a conversation. I'll give you more information about the Policy Advisory Board. Okay, thanks.
Thank you. It's so nice to see you, Ryan. Okay, so that was the update of where we are with positions here. And please, if you know of anybody, doesn't matter which island you live on, please ask them because we're always willing to get more people aboard. Okay. Number 4, proposed focus for 2026 and related to the state plan on aging. Some of you may think, oh, that was just a book and I put the book away someplace, but I don't know where the book is. Okay. And if you don't know where the book is, it's on the website. Okay. But, this came to us and we said, when we think about where we go legislatively or wherever we are working with things, we should always keep first the state's strategic plan, because that's our guiding point of everything legislatively. And I'm sorry, I was negligent too. But as a legislative committee member, one of the top bills that PABEA should follow is the state budget. And why the state budget? That's where all the funds come down to us, okay, for us to fund everything in our counties. And without that funding, our counties will not be able to function the way that we like them functioning right now, okay? So I know, sitting in our legislative committee's meeting today, they adopted this as their guideline of what they would like to follow for this legislative session. To help you a little bit more, and I thank Director for this, is that we put down what goal and what objective it would come under. So the only suggestion I can make is that as you folks go forward, and this is for anybody on the committee, okay? If there happens to be a legislative bill you find under there that maybe we may have missed, and bills won't come out until after January, ending of this January, okay? So by first week of February, they will be logging in. For those of you who like safety for Kupuna, I would go on the government website, and as you track bills, just track bills for that. Because then you will receive all information just for that area. Okay, but that's just to keep you a little bit more informed of why this is here on the agenda there. Okay?
Could I
Caroline?
just add?
Yep.
If you do, can't remember, because we handed out copies a while ago, if you do wanna, if you're one of those that really needs a hard copy, because some people don't like to have to flip online, I'm happy to, we still have some hard copies, just see me after the meeting.
Thank you.
Can
And
I
now,
show you? So I use sticky notes. Because that's who I am. And I found it really helpful to look to see. And I figure as we go through, we can almost prioritize those essential services that we should focus on. Because under the, like, safety, there's like oodles and oodles and oodles of stuff. And if we figure out as a group what our top priorities might be, then it'll be the list will be a lot smaller.
good suggestion. Thank you.
Can I add one more thing? I'm sorry, this is boring good conversation, is our area agencies on aging also, they follow the same topic areas and they have specific goals and objectives, objectives that relate to just their county. So if you're interested in your own county, all those are up on the website too, so you can go take a look at that and how they're addressing it.
And I think PPRC can also chime in on that, correct, Lisa? Is that now the areas are following their goals and objectives when they're writing the reports. So it's easy for anybody on PABEA to know exactly what each county is doing. So we appreciate what the counties are doing on that part, okay? Public testimony, is there any public testimony from appointed members?
I would like to, yes, just very short. I'm a member of the Hawaii Farmers Union, which is a statewide organization of family farmers. And they are also weighing in and looking at the priorities on the legislative priorities. And their top number one is establishing a food hub. That's what they're calling it. It's a food hub. It's a slash anti-hunger initiative that they are working with. I'm not sure who yet, but they're working on writing some bills in support of the food hub providing greater access to food and to access to lowering the cost of the community sustained ag boxes and that kind of thing, which sort of fits in with sort of a we're all in this together kind of thing. So there are lots of other organizations throughout the state who have the same idea, the same like mind. We have to work together as a community to put this all together to make it through the next couple of years.
Thank you. Okay, anybody else with public testimony? No? Okay,
Anyone online?
going into PABEA reports. Oh, I'm sorry, I jumped myself. The appointed members should come now. The public was the public. I'm so sorry. I reversed it. So sorry, Sarah. Okay, now we will go into ex officio. And first, I think we will introduce our new member from the Department of Education, Ryan. Ryan, how do you pronounce your last name? Because I don't want to crucify it.
My last name is pronounced Mandado.
Madonna. Okay,
Yeah.
maybe you would like to introduce yourself a little bit to us?
Sure. Hi, everyone. My name is Ryan Mandado. Thank you so much for allowing me to be part of this group. Born and raised in Kalihi, I went to public school my entire life. And now I serve in a new capacity at the Department of Education supporting adult education. And so if you're not familiar with adult education, we have about 10 campuses statewide that provide a variety of different educational services to adults. And so folks who are interested in getting their GEDs or high school equivalency and other related training opportunities, we have programs for that. We also have a program in corrections. And so if there's any programs related to elders in corrections, we're able to assist with that as well. I guess my role here is really about building partnerships amongst your organization and other organizations you feel need more support with adult education. And I'm here to facilitate those partnerships. So if there's anyone you feel like I should connect with, or feel like there is a strong interest in a particular class or extended learning, please get me involved. I'm really energized and new in this position, and so really interested in providing those services to our elder populations.
Well, thank you so very much. You know, we appreciate that. And I'm quite sure that people with adult education are very, very happy that you folks are out there for them. Okay, going on, Department of Human Services, Kathy.
Hi, this is Kathy. I have no updates at this time.
Okay, thank you, Kathy. Paula, Department of Health.
Hi,
Happy New
everyone.
Year.
No additional updates other than what was in my written report, which was submitted. You guys have.
Okay, thank you so much. I'm just looking down our list. I don't see anybody else. I don't see Alan.
Alan's usually here.
Alan is usually here, but I don't see Alan. Correct? I don't see Alan. Okay. Okay, the most important guy. Oh, I'm sorry. We'll go back to public testimony since I missed that earlier. Anybody would like to give a public testimony? Okay, seeing none. Agency reports. Thank you very much, all of the directors, for submitting your written reports. Everybody has had a very busy session. So going on, let's see. Kauai, you're first.
Hi, everyone. I just wanted to say thank you and Happy New Year. Oh, sorry, my screen is all weird. No big updates, just that we're planning for Older Americans Month. Something that we did recently is trying to do some like intergenerational type things. So we had a few events last month where we collaborated with Hilo Intermediate, their Hawaiian club and their robotics club. And they kind of taught some of our kupuna here about the robotics, and then chant mele, and they just engaged in those events together. We got really good feedback from it, that we're now going to start planning for another one in spring. So because it's in the spring, we're thinking like growing together, and so we're bringing in like plants, how to be sustainable on your own, and again mixing with the youth and the kupuna. So that's something that we're hoping to continue. And yeah, other than that, Older Americans Month's really on our mind right now. So that's about it for us.
Thank you so much. Jay, City and County of Honolulu, Derek. You have to step. Oh, sorry. Okay, so let's go on to Emily.
I don't think anything new that wasn't added in our report, but speaking of older Americans, we are in the process of getting together and finding a date that works for everybody on the island. And actually, one more thing, we are in the process of planning our next Elder Justice conference. So that will be held in June, because that's Elder Abuse Awareness Month. So that is going to be coming up. We're excited about that. I'm trying to get a lot of community involved and focus on financial fraud. And crypto, a new trend, the cryptocurrency. So, and thank you to Bev, because she also sits on that team, that committee, and gives her input.
Okay, thank you. Maui County, Rowena.
So for Maui County, we submitted our report, and in it was the discussion that I think the Plans and Policies Committee wanted to have regarding long-term services and supports and servicing underserved populations. So there was a definition of how we define underserved populations and the strategies that we use, which also includes some information about how we contract with providers on Molokai and Lanai and those hard to reach areas. That's kind of that's our big focus for the coming year, is to see how we can engage closely with those communities. And listening to the presentation from Navian Hawaii today, that would have been one of my questions, is how can we engage organizations like you more in these rural areas where healthcare is a big concern among the senior population. So that discussion is in our report. I also wanted to share that in it, I also have something in there about our partnership with emergency management and how they helped us distribute almost 10,000 meals, ready to eat meals to seniors in the communities, including Molokai, Lanai, and Hana. So that was a big operation in December, and that's about it. Oh, our outstanding older Americans luncheon is scheduled for May the 15th. That's a Friday at the Cameron Center.
Okay, thank you. Unfortunately, Derek's not here, but he did submit his written report, and they are moved into their new facility. And like he even said earlier, they're kind of adjusting to it all, but you know, like every place, wherever you move in to a renovated home, a new place, it takes a while to get adjusted to it all. Our next monthly PABEA meeting will be on Friday, February 6th at noon. Kapuna Caucus is this afternoon, January 9th. At 2 p.m. via Zoom. And did you get anything else?
Ryan, just put into the chat his email, but it will be part of our PABEA, list
Right.
of kids, so, thank you.
Yeah, okay. So that will be there, and from Sarah, from Gary and Sarah, the online
Sarah
Hawaii,
Yuan.
from Sarah
have a hard
Yuan,
copy
sorry,
also.
Sarah Yuan. We have two different Sarahs, sorry about that. Gary had sent this out earlier on behalf of the Fall Prevention Group. And it's a Hawaii Falls Prevention Landscape Survey. Survey doesn't take long to fill out. And it is going to be helpful to them. So please take a few minutes just to fill it out. If you know other people who can fill it out, I think they're looking for as much information as they can. Isn't that correct, Gary? They want a cross group of people to reply to the survey?
Correct. As wide a net as possible, wide and deep.
Okay, thank you.
And there's, you need a paper.
Gary, is there a deadline for this?
No, we want to get a critical mass, so we didn't have a deadline yet. But but get to it as soon as you can.
Okay, thank you. Yeah, because I didn't think I saw a deadline on that,
No,
so,
no.
okay, thank you. Okay. Yeah, our next meeting will be then February 6th. Kapuna Caucus is this afternoon. And as you heard, both Richmond and Dan, they are going to be doing a presentation. I believe it is on palliative care, if I'm not mistaken.
Yeah.
The value of palliative care in Hawaii. Okay, and that is their presentation for this afternoon. Okay, without any further ado, it is now 1:08 p.m. We will adjourn this meeting. Thank you all very much and have a great day.
Thanks.